Welcome to the Weekly Neurology Deep Dive. This week, we're diving into cerebral autosomal dominant arteriopathy with subcortical infarcts and leukoencephalopathy. We'll just call it CADASIL, of course.
Right.
This deep dive is produced by Amer Gavanini.
And our goal today is, well, pretty focused. We want to synthesize the latest findings for you, the clinical neurologist. We're aiming for a practical, evidence-based overview covering, the pathophysiology, clinical features, those important genotype-phenotype links, and current diagnostic thinking.
Okay, but before we really get started, we have to state this clearly. This is purely for education. There's absolutely no commercial goal here. Think of this as a summary, a synthesis of recent data. For the full picture, we strongly recommend reading the original papers.
Absolutely. And for those of you short on time, let's kick off with a very practical summary. These are the things you really should keep in mind for your clinical practice, especially when dealing with unexplained cerebral small vessel disease.
Right, let's start with prevalence. This is, frankly, a game changer. You almost need to rewire how you think about CADASIL's frequency. It's far more common than we used to believe. Recent large genomic studies suggest pathogenic NOTCH3 variants are found in up to 3.4 per 1,000 people in the general population.
Which is just staggering. That's a 100-fold increase compared to the older estimates. It means you are almost certainly encountering carriers in your clinic, perhaps many with very mild or, atypical presentations. And we see the highest risk among Asian populations.
Okay, so prevalence is way up. What about diagnosis and pathology basics?
The gold standard hasn't changed. It's genetic testing for that NOTCH3 mutation. Pathologically, the absolute hallmark is finding granular osmiophilic material. This stuff is mostly made of the NOTCH3 extracellular domain, and it builds up around the vascular smooth muscle cells in those small arteries.
And clinically, what are the key clinical predictors neurologists should look for?
Think about the typical timeline. Migraine, often with aura, usually kicks in first, maybe around age 30 on average. Then come the recurrent strokes, typically subcortical, starting somewhere between 40 and 59 years old. And then noticeable cognitive impairment or even dementia tends to show up later, maybe mean onset around 50 to 59 years.
And for neuroimaging distinction, what stands out on the magnetic resonance imaging?
Definitely look for those high specificity signs. White matter hyperintensities in the anterior temporal lobe, also in the external capsule. But here's a crucial point for prognosis. Predicting actual disability and cognitive decline seems less about the total white matter hyperintensity volume and more about the volume of lacunes and the overall degree of brain atrophy. Those are the strongest magnetic resonance imaging predictors.
That's a really practical point. And what about genetics for prognosis, the genotype severity rule?
Yes, this is maybe one of the most actionable genetic insights right now. If the pathogenic variant affects epidermal growth factor-like repeats 1 through 6, expect a significantly earlier onset about 12 years earlier, based on the data, and a generally more severe phenotype compared to mutations hitting epidermal growth factor-like repeats 7 through 34.
And finally, management focus.
Well, we don't have specific disease-modifying therapies yet, unfortunately, so the focus absolutely has to be on aggressively managing those modifiable environmental risk factors. Hypertension and smoking, they are clearly identified as strong modifiers that worsen disease severity. You have to tackle those head-on in every single CADASIL patient.
Okay, that's the essential takeaway up front. Now let's really dig into the data behind these points. Let's start with the genetics and epidemiology. How do we miss this prevalence for so long?
So fundamentally, CADASIL is an autosomal dominant disorder. It's all about mutations in one gene, NOTCH3, located on chromosome 19. This gene codes for a transmembrane receptor, a single pass one, that plays a critical role in how vascular smooth muscle cells function and survive.
And that receptor structure is key, right? Especially the extracellular part.
Exactly. The extracellular domain is huge, characterized by 34 tandem epidermal growth factor-like repeats. And that's where almost all the trouble starts. You see, normally each of these repeats has 6 cysteine residues. These form 3 very precise disulfide bonds, which are essential for folding the protein into the correct 3-dimensional shape.
But the mutations mess that up.
Precisely. We know of over 280 different pathogenic mutations now. Most are found in exons 2 through 24, the ones coding for those epidermal growth factor-like repeats. The general rule is that a pathogenic mutation results in an odd number of cysteine residues within a repeat. This disrupts those crucial disulfide bonds, leading to misfolding and, critically, aggregation.
But you mentioned exceptions earlier. The odd cysteine rule isn't absolute. What about those cysteine-sparing missense mutations or loss-of-function ones? How do they fit in?
That's an excellent point, and it highlights the complexity. The main story is toxic gain of function through aggregation due to unpaired cysteines. But yes, there are rare cases. For instance, a mutation like PRG75-Pro replaces an arginine with a proline. No cysteine change, but it still destabilizes the receptor structure enough to cause disease. Similarly, true loss of function mutations have been reported. This suggests that sometimes not having enough functional NOTCH3 signaling might also contribute to the phenotype, though aggregation is still the dominant mechanism for most. These rarer variant types are often where a skin biopsy becomes really useful, providing pathological evidence if the genetic finding alone is a variant of uncertain significance.
Okay, that makes sense. Now let's circle back to that prevalence shift. It's just astounding. We went from thinking 1 to 4 per 100,000.
Right. Based on those older retrospective European studies that mainly captured families with severe, obvious clinical disease. They were looking where the light was brightest, essentially. But then came modern large-scale genomic sequencing of general populations. Projects like the Exome Aggregation Consortium and the Genome Aggregation Database screened thousands of unselected individuals. And they found pathogenic NOTCH3 variants in roughly 3.4 per 1,000 people.
100 times more common. It implies most carriers are either asymptomatic or have very mild, maybe late onset symptoms, perhaps just some white matter changes found incidentally,
Yeah.
or minor cognitive issues later in life that never get formally linked to CADASIL.
Exactly. It completely reframes how you should think about unexplained cerebral small vessel disease, doesn't it? It's not necessarily some zebra anymore.
And it's not evenly spread. You mentioned geographic hotspots.
Yes, definitely higher frequency in Asian populations. Take Taiwan, for example. One specific mutation, PRG544CCs, is carried by about 0.85% of the general Taiwanese population. That's an incredibly high carrier rate for a single pathogenic monogenic variant.
Which has immediate clinical relevance in stroke units there, presumably.
Absolutely. It means NOTCH3 mutations aren't just a rare genetic finding, they're a significant risk factor for stroke. Studies from Taiwan found these mutations at about 5 to 7% of patients presenting specifically with small vessel occlusion stroke. So if you have a younger patient, particularly of Asian descent, with a lacunar stroke syndrome, testing for NOTCH3 really moves up in the differential diagnosis.
Looking closer at the mutations themselves, they aren't scattered randomly across the gene, are they?
No, there are definite hotspots. While the gene has 33 coding exons, most CADASIL-causing mutations cluster in exons 2 through 6. European studies consistently find exon 4 to be a major hotspot, accounting for something like 55 to 73% of all mutations identified in those populations.
And the ethnic differences suggest founder effects.
Very strongly. In Japan, for instance, 2 mutations in exon 4, PRG133Cs and PRG188-2TCs are particularly common. Contrast that with central Italy, where a different mutation, PRG1006Cs and exon 19, is the most frequent, found in about 16% of their cases.
And East Asia has its own dominant mutation.
Yes, the PRG544CC's mutation really stands out across Taiwan, Jeju Island, and Korea, and parts of mainland China. On Jeju Island, it's particularly striking something like 90% of the known CADASIL pedigrees carry this single mutation. It really underscores why genetic testing needs to account for these regional variations. You can't just rely on panels based on European data.
Understanding this prevalence and distribution is vital, especially because, as you said in the summary, where that mutation actually lands on the receptor seems to directly impact how severe the disease gets.
Right.
Okay, let's shift from the who and where to the how. How does this mutated protein actually damage the blood vessels? Let's get into the pathophysiology.
The absolute key, the thing you see under the microscope, is the deposition of granular osmiophilic material, which we often just call GOM. This material builds up outside the cells, mainly in the media and adventitia layers of the small arteries and arterioles in the brain. It surrounds those critical vascular smooth muscle cells and also the pericytes.
And this granular osmiophilic material, it's basically chunks of the bad protein.
Primarily, yes. It's composed mainly of the NOTCH3 extracellular domain. Because the mutation causes that odd number of cysteines, the protein misfolds and becomes really prone to clumping together multimerization. This aggregation makes it less soluble and much harder for the body to clear away. So it essentially sticks to the vessel wall like glue.
Which leads to the main hypothesis, the toxic NOTCCH3 extracellular domain aggregation idea.
Exactly. When this multimeric, misfolded NOTCH3 starts accumulating inside the cell, particularly within the endoplasmic reticulum, It causes significant endoplasmic reticulum stress.
And that stress isn't passive. It actively triggers downstream problems.
Right. Endoplasmic reticulum stress can activate various signaling pathways, and one notable one is the Rho-RO kinase pathway. Activating this pathway seems toxic to the vascular smooth muscle cells. It leads to abnormal cell growth, impairs their function, and ultimately results in reduced vasodilation. The vessels can't relax properly, and that's severely impaired vasoreactivity that's characteristic of CADASIL.
So the vessel walls become stiff and unresponsive. What about the GOM accumulating outside the cells?
That causes problems too. The sheer bulk of this extracellular, granular, osmiophilic material seems to physically interfere with normal vessel function.
Yeah.
It might actually block or impede the intramural periarterial drainage pathways, the brain's waste clearance system that runs along vessel walls. While the impaired vasoreactivity is probably the main driver of the ischemic damage, this physical blockage likely contributes significantly to the white matter degeneration by impairing clearance.
Okay, that's the aggregation hypothesis. What about the second idea, the aberrant NOTCH3 signaling? This seems more complex.
It is definitely more complex. The normal NOTCH3 signaling pathway is intricate. The receptor needs to be cleaved sequentially. First, an S1 cleavage, then S2 cleavage by enzymes called a disintegrin and metalloproteinase, and finally, the critical S3 cleavage by gamma secretase. This releases the NOTCH intracellular domain, or NICD. The NICD then travels to the nucleus and activates a key transcription factor called RBPJK, turning target genes on or off.
But the studies on how CADASIL mutations affect this signaling are conflicting, right?
They really are. Some studies show that certain pathogenic mutations clearly impair the receptor's ability to bind its ligand or even get to the cell surface properly. This would lead to reduced signaling, suggesting a loss of function component.
But then other studies show the opposite, or normal signaling, despite the obvious aggregation.
Exactly. Some research suggests increased signaling activation with certain mutations. Others find that signaling seems intact even when the protein is clearly misfolding and causing problems with trafficking inside the cell. This makes therapeutic targeting really tricky. For instance, if you're thinking about using a gamma secretase inhibitor, you need to know if you're trying to reduce a toxic gain-of-function signal or if you risk worsening a loss-of-function situation.
So the takeaway is that it's likely mutation-specific.
That seems to be the most plausible conclusion from the current data. The disruption of this tightly regulated signaling cascade is central to the pathology, but whether it's a net loss or gain of function likely depends heavily on the specific mutation and its location on the receptor. It's not a one-size-fits-all mechanism.
And the damage isn't just the protein itself. It involves the surrounding extracellular matrix, the matricome.
Yes, the granular osmiophilic material isn't pure NOTCH3. When you analyze it, you find it incorporates other important proteins associated with the extracellular matrix. Key examples include metalloproteinase inhibitor 3, also known as TIMP3, vitronectin, and significantly high-temperature requirement protein A1, or HTRA1.
High-temperature requirement protein A1, that's the gene mutated in CADASIL, another inherited small vessel disease, isn't it? Cerebral Autosomal Recessive Arteriopathy with subcortical infarcts and Leukoencephalopathy.
Exactly. The fact that high-temperature requirement protein A1 gets pulled into the granular osmiophilic material in CADASIL is a really important clue.
It suggests that maybe the GOM is sequestering high-temperature requirement protein A1, preventing it from doing its normal job.
That's the thinking. By trapping high-temperature requirement protein A1, the GOM essentially mimics a functional loss of this protein. Loss of high-temperature requirement protein A1 function is known to lead to increased signaling through the transforming growth factor pathway. This, in turn, promotes the deposition of excess extracellular matrix components. The end result is arterial stenosis, a thickening and narrowing of the vessel wall, which worsens the existing cerebral hypoperfusion and makes the brain tissue even more vulnerable to ischemia. So the GOM is doubly bad: toxic aggregation and promotes restrictive matrix buildup.
Okay, so we have this complex picture of vessel damage. How does this translate into what we see in the patient? Let's talk about the clinical manifestations and the significant heterogeneity.
Right, we know the classic quartet of symptoms, often appearing sequentially. First, typically, is migraine, often with aura. The mean onset is around 30 years old. It's frequently the earliest sign. Second, recurrent subcortical ischemic strokes. These usually start manifesting between ages 40 and 59. Third, mood and psychiatric disturbances. Depression is the most common, reported in about 24% of patients in one large review. And fourth, progressive cognitive impairment leading eventually to dementia, with a mean onset typically in the 50s, maybe 50 to 59 years.
But neurologists need to be aware of the atypical presentations too, the ones that might lead you down the wrong path initially.
Absolutely. Epileptic seizures, for instance, occur in about 5 to 10% of CADASIL patients. Not the most common feature, but definitely present. More dramatically, there's the acute encephalopathy, sometimes called CADASIL coma. This affects roughly 10% of patients and can present quite alarmingly with severe, prolonged headaches, confusion, sometimes seizures, or fluctuating focal deficits. It can look like Prius or encephalitis initially. And we also see movement disorders reported, though less commonly, things like ataxia or Parkinsonism have been noted in about 4% of reviewed cases.
Now, the really critical variations seem to come down to ethnic and genotype differences. Comparing European and Asian cohorts reveals some stark contrasts.
Yes, particularly when you compare cohorts predominantly carrying the common European mutations versus those like in East Asia, dominated by the PARG544-CEASE mutation, the phenotypes can look quite different.
The most striking difference seems to be the risk of bleeding.
It really is. The incidence of intracerebral hemorrhage is dramatically higher in Asian CADASIL cohorts, reported anywhere from about 17% up to 25%. Contrast that with European cohorts, where intracerebral hemorrhage is considered very rare, maybe only 0.5 to 2% incidence. This has major implications for how you manage anticoagulation or even antiplatelet therapy in an Asian patient with CADASIL.
And conversely, migraine seems less common in Asian patients.
Markedly so. The prevalence of migraine in Asian patients with CADASIL is reported much lower, maybe in the range of 3 to 28%, whereas it's a hallmark feature in many European descriptions. It suggests that perhaps the PARG544B's mutation confers a lower migraine risk, but simultaneously increases the propensity for microvascular bleeding.
Which is backed up by the imaging findings on cerebral microbleeds.
Exactly. Cerebral microbleeds are found much more frequently in Asian patients. About 66 to 74% carry them, compared to lower rates in Caucasians. And importantly, the studies highlight specific risk factors for future intracerebral hemorrhage in these patients. Having cerebral microbleeds located in the brainstem, or having a total count of more than 10 microbleeds anywhere in the brain, those seem to be independent predictors of future hemorrhage risk.
We also need to acknowledge the variable severity more broadly now, don't we? We're recognizing milder forms.
Yes, absolutely. Our historical view was skewed towards the severe, classic, often familial cases that were easier to identify. But with wider testing and awareness, we're now recognizing late-onset CADASIL with much milder phenotypes much more frequently. There are well-documented cases where the first stroke didn't occur until the patient was in their late 70s or even 80s. Ages like 79 or 86 have been reported. It tells us the clinical spectrum is incredibly wide, ranging from devastating early onset disease to very subtle late-life presentations.
And the typical ages of onset for the main symptoms, migraine around 40, stroke around 52, cognitive decline around 55. In some larger cohorts that supports this idea of slow cumulative damage over decades.
Yeah, it does. It fits the picture of chronic small vessel failure, leading to the gradual accumulation of lecunar infarcts and white matter damage, eventually crossing a threshold where clinical symptoms become apparent.
Which brings us back to those environmental modifiers. If people with the same mutation can have such different outcomes, external factors must play a big role.
They clearly do. Even within the same family, carrying the identical NOTCH3 mutation, you can see significant variation in severity and age of onset. And the main environmental factors consistently implicated are hypertension and smoking. Multiple studies identify these as strong risk factors associated with earlier stroke onset and more rapid progression to dementia in CADASIL patients. They likely exacerbate the underlying vascular pathology by increasing arterial stiffness and further impairing vascular reactivity. So, while you can't change the gene, you absolutely can and must target these modifiable risks. Okay, let's talk about diagnosis and practice. Genetics gives the definitive answer, but magnetic resonance imaging is usually the first clue and provides really critical prognostic information.
Right, you're looking for the standard cerebral small vessel disease markers we see in other conditions, Leukoens, white matter hyperintensities, maybe cerebral microbleeds, and brain atrophy. But what are the specific magnetic resonance imaging features that should make you strongly suspect CADASIL?
Two locations for white matter hyperintensities are highly characteristic. First, the anterior temporal lobe. Seeing significant white matter hyperintensities there has a reported sensitivity of about 89 to 90% and very good specificity, around 86 to 100%, for distinguishing CADASIL from controls or sporadic small vessel disease. We do need to remember that caveat, though: the prevalence of this specific finding might be lower in some East Asian cohorts, perhaps only 20 to 71%, potentially linked to that PR544C genotype.
And the second key location.
White matter hyperintensities in the external capsule. This finding also have high sensitivity, about 93%, although its specificity is lower, around 45%. But sieve involvement in both the anterior temporal poles and the external capsules together is highly suggestive of CADASIL.
There was also mention of more subtle finding, linearly arranged lacunes.
Yes, an older observation that seems quite specific, though maybe less sensitive. Some studies described subcortical lacunar lesions, often appearing almost lined up, frequently right at the junction between the gray and white matter. One study found this in about 59% of their cohort, but reported it had 100% specificity for CADASIL compared to other cerebral small vessel disease types. Worth keeping an eye out for.
Okay, those are diagnostic clues. But you emphasized the prognostic value of magnetic resonance imaging earlier. What tells us how the patient is likely to do long term?
This is really key for counseling. While we often focus on white matter hyperintensity volume in general small vessel disease, in CADASIL, the strongest independent predictors of future disability and cognitive decline seem to be the burden of lacunes, their number, and total volume. These are significantly associated with poor outcomes, with p-values less than 0.01 in several studies.
And brain atrophy.
Brain atrophy is the other major player. Measures like the brain parenchymal fraction, which quantify overall brain volume loss, correlate very strongly with both cognitive dysfunction and physical disability. Critically, the degree of brain atrophy at baseline independently predicts the future risk of incident stroke, developing dementia, and worsening disability, again with strong statistical significance. P-value less than 0.01. It really seems to reflect the cumulative irreversible damage from the underlying vasculopathy.
It's interesting that white matter hyperintensity volume itself wasn't independently predictive after accounting for lacunes and atrophy. And what about cerebral microbleeds?
Cerebral microbleeds were initially associated with an increased risk of future stroke, about a 1.87-fold increased risk in one analysis, p-value less than 0.01. However, that association disappeared after adjusting for the burden of lacunes and the degree of brain atrophy. This suggests that while microbleeds might indicate vessel fragility, particularly relevant for hemorrhage risk in certain populations, the overall burden of ischemic damage, lacunes, and resulting tissue loss, atrophy, are the more powerful drivers of long-term clinical decline in CADASIL.
So imaging is crucial for clues and prognosis. Genetic testing is the gold standard for the diagnostic approach. Where does the skin biopsy fit in these days?
It still has a role, albeit more limited one. A skin biopsy looking for granular osmiophilic material deposits in the vascular smooth muscle cells of dermal arteries is highly specific. You can confirm these deposits using electron microscopy or immunohistochemistry staining for NOTCH3. If you find GOM in the skin, it's very strong evidence for CADASIL.
But it's not used routinely. Why not?
The main issue is sensitivity. It's quite variable and can be low. One large review reported only about 14% of genetically confirmed CADASIL patients had a positive skin biopsy. Sensitivity seems to depend on factors like the biopsy site, the patient's age, and disease severity, so it's generally reserved for specific situations. Maybe investigating patients with variants of uncertain significance found on genetic testing, or cases where genetic testing is negative but clinical suspicion remains extremely high, or perhaps for those rare cysteine-sparing mutations where pathological confirmation is particularly valuable.
Looking ahead, are there promising blood biomarkers on the horizon for diagnosis or monitoring?
There's definitely progress here. The most studied and perhaps most promising candidate currently is neurofilament light chain, or NFL. Serum neurofilament light chain levels are significantly elevated in CADASIL patients compared to controls, and crucially, these levels correlate strongly with the magnetic resonance imaging markers of cerebral small vessel disease burden, like lacune volume and white matter hyperintensity volume.
And it has prognostic value, too.
Yes, quite powerfully. Higher serum neurofilament light chain levels predict future stroke, cognitive decline, worsening disability, and even mortality in CADASIL patients, with studies reporting p-values less than 0.01 for these associations. What's particularly interesting is that researchers observed a sharp increase in serum neurofilament light chain levels starting around age 40. This timing aligns perfectly with the typical age when the burden of lacunar infarcts really starts to accelerate in these patients, suggesting NFL reflects that ongoing axonal damage.
The obvious limitation being that neurofilament light chain isn't specific to CADASIL, right? It reflects axonal injury from many causes.
Exactly, that's the major caveat. Elevated neurofilament light chain tells you neurons are dying, but not necessarily why. However, within the context of a patient with known or suspected CADASIL, it could become a valuable tool for monitoring disease activity or even response to future therapies. The sources also mention other potential future blood biomarkers being investigated, like measuring the levels of the NOTCH3 extracellular domain itself, which might be decreased in the blood because it's getting trapped in the GOM deposits. And maybe measuring levels of high temperature requirement protein A1 or endostatin could also prove useful down the line.
Let's really focus now on those genotype-phenotype correlations. This seems incredibly important for giving patients a realistic idea of what to expect.
It absolutely is. And the single most important factor determining disease severity appears to be the position effect specifically, where the mutation occurs within those 34 epidermal growth factor-like repeats in the NOTCH3 receptor. The key takeaway is this. Mutations located in epidermal growth factor-like repeats 1 through 6 near the N-terminal end of the receptor consistently predict a more severe classic CADASIL phenotype.
And the data quantifies that severity difference quite starkly.
It does. Patients with mutations in that epidermal growth factor like repeats 1 to 6 region experience stroke onset, on average, about 12 years earlier than those with mutations in repeats 7 through 34. They also tend to have a shorter overall survival time by about 8.4 years, according to one major study. That 12-year difference in stroke onset is a massive difference when you're counseling a young patient diagnosed in their 30s or 40s.
Is there a biological reason why the location matters so much?
It seems to tie back directly to the aggregation pathology we discussed. Studies suggest that mutations located further down the chain, in epidermal growth factor-like repeats 7 through 34, tend to result in proteins with milder aggregation properties. Consequently, these patients tend to accumulate less granular osmiophilic material in their vessel walls, leading to a slower progression and later onset of symptoms. This location-based risk stratification is arguably one of the strongest prognostic indicators we have in CADASIL right now.
Okay, location is key. What about the impact of mutation type? We touched on the cysteine-sparing ones earlier, and the data seemed a bit confusing.
It is still somewhat confusing for those rarer types. Cysteine-sparing mutations, like the PRX75 Pro example, generally cause a clinical picture similar to classic CADASIL. Some studies suggest they might be associated with a later onset and, interestingly, less frequent involvement of the anterior temporal pole on magnetic resonance imaging, maybe only about 29% involvement compared to about 77% in typical cysteine involving mutations in one study.
But then another study found the opposite regarding onset age.
Yes, that's the contradiction. A large review actually found that patients with cysteine-sparing mutations had a significantly earlier mean age at onset, around 43 years old, compared to those with the typical cysteine-involving mutations, whose average onset was around 51 years old, p-value less than 0.01. It really highlights that these non-canonical mutations might disrupt the NOTCH3 receptor function or structure in different ways, and we still need more research to fully understand their specific risk profiles. We can't just lump them all together.
What about the extremely rare situation of homozygous mutations, inheriting a faulty gene from both parents?
Patients identified with homozygous NOTCH3 mutations generally seem to present with symptoms within the typical CADASIL spectrum. There isn't strong evidence for a completely distinct phenotype. However, some case reports in smaller series do suggest that having 2 mutant copies might lead to an overall increased disease severity or possibly slightly earlier onset compared to heterozygotes, which intuitively makes sense, but more data is needed.
Can we use computational tools to predict severity? You mentioned the combined annotation-dependent depletion CAD pathogenicity score.
Yes, the CADA score is an attempt to computationally estimate how deleterious a specific genetic variant is likely to be based on evolutionary conservation and other factors. And studies in CADASIL have found a significant inverse correlation between the CAD score of a patient's mutation and their age at symptom onset, p-value less than 0.01. In simple terms, mutations with higher CAD scores predicted to be more damaging tend to cause the disease to start earlier. This could potentially become another tool for risk stratification in the future.
And finally, are there sex differences in presentation or severity?
There do appear to be. Overall, women with CADASIL tend to have a somewhat less severe phenotype compared to men, with statistical significance reported in some large cohort studies, p-value less than 0.01. Interestingly, though, migraine is significantly more common as a presenting symptom in women. One analysis found it was reported about 44% more frequently in women than in men. The reasons for this aren't entirely clear. It could be ascertainment bias. Perhaps women get diagnosed earlier because the migraine brings them to medical attention sooner, leading to potentially better risk factor management. Or there might be some underlying biological or hormonal protective effect against the more severe stroke and dementia outcomes in women. It's an area needing more research. Now, we really need to challenge the traditional view of CADASIL. The name itself, Cerebral Autosomal Dominant Arteriopathy, with subcortical infarcts and leukoencephalopathy inherently limits our thinking to the small vessels of the brain. But the evidence is mounting that NOTCH3 pathology is much more widespread.
This really broadens the scope of the disease, doesn't it? Away from just brain small vessel disease. You're talking about intracranial and extracranial large artery involvement.
Exactly. We're seeing increasing reports of anomalies in the large intracranial arteries in CADASIL patients, things like arterial stenosis, vertebral artery hypoplasia, a common trunk for the anterior cerebral arteries, or persistence of fetal posterior cerebral artery circulation. One study, particularly from East Asia, where this seems more commonly reported, found that about 76% of their CADASIL patients had at least one such large artery abnormality.
And is there pathological proof that this is related to the NOTCH3 mutation itself, not just coincidence?
Yes, that's the crucial part. Pathological studies have definitively found granular osmiophilic material, the hallmark deposit in the walls of large arteries outside the brain, including the aorta, the carotid arteries, and even renal arteries. This clearly demonstrates that the consequences of the NOTCH3 mutation aren't confined to the tiny cerebral arterioles. The receptor failure affects vascular smooth muscle cells in medium and large arteries throughout the body. This might even explain some atypical presentations, like markedly asymmetric white matter changes perhaps driven by hypoperfusion from an upstream large artery stenosis.
And the heart is involved too. Coronary artery disease and microvascular dysfunction.
Yes, there's clear evidence here as well. Histopathologist studies of heart tissue from CADASIL patients show the same characteristic changes in the coronary microvasculature: granular osmiophilic material deposition, smooth muscle cell degeneration, and thickening of the basement membrane. Clinically, this translates into links between NOTCH3 mutations and ischemic coronary artery disease. Often, it doesn't present like typical plaque rupture myocardial infarction, but rather as coronary microvascular dysfunction patients might have angina symptoms. But angiography shows patent large arteries, yet they have objectively measured reduced coronary flow reserve. Diffuse coronary stenosis, distinct from typical atherosclerosis, has also been described. So if a CADASIL patient presents with chest pain or cardiac symptoms, you have to consider that it might be directly related to their NOTCH3 vasculopathy, not just standard coronary artery disease.
And beyond the vessels, there are hints of metabolic abnormalities.
There are suggestive links, yes. We know NOTCH3 signaling pathways intersect with metabolic regulation. Some research proposes connections between NOTCH3 mutations and hyperlipidemia. One suggested mechanism involves downregulation of apolipoprotein D, which plays a role in lipid transport. There's also intriguing basic science work linking the delta-like 4 NOTCH3 signaling pathway to diabetic vasculopathy. In vascular organoid models, exposure to high glucose conditions induced thickening of the basement membrane, a change also seen in diabetic microvascular damage. Blocking the interaction between delta-like 4 and NOTCH3 actually reduced this thickening. This raises the possibility that the NOTCH3 mutation might sensitize vessels to the damaging effects of hyperglycemia, potentially accelerating diabetic-like vascular changes.
But we need to be cautious here, right? It's hard to separate the direct effect of the NOTCH3 mutation from the high prevalence of traditional risk factors in these patients.
Absolutely critical point. A major clinical consideration is untangling the primary NOTCH3 pathology from the effects of coexisting hypertension, diabetes mellitus, smoking, and even potentially higher rates of background intracranial atherosclerosis, especially noted in some of the Asian cohorts where large artery involvement seems more common. Are the large artery findings and coronary issues purely due to NOTCH3? Or is it an interaction effect with traditional risk factors accelerating damage in susceptible vessels? We urgently need more longitudinal studies designed specifically to dissect these contributions.
We've covered an immense amount of detail. really reshaping the view of CADASIL from a rare brain disease to a more common systemic vasculopathy. Let's quickly recap those essential practical summary points one last time for the busy neurologist.
Okay, first, prevalence. Remember that 3.4 per 1,000 number for pathogenic variants. CADASIL is much more common than previously thought. It's likely underdiagnosed.
Second, diagnosis. Gold standard is the NOTCH3 mutation detection. Pathologically, look for that granular osmiophilic material around vascular smooth muscle cells.
Third, magnetic resonance imaging for prognosis. Focus on the quantitative measures, the volume and number of lacunes, and the degree of overall brain atrophy. Don't forget the characteristic white matter hyperintensities in the anterior temporal lobe and external capsule as diagnostic clues.
Fourth, genotype counseling is key. Mutations in epidermal growth factor-like repeats 1 through 6 mean earlier onset, about 12 years earlier, and a more severe course compared to mutations in repeats 7 through 34.
And finally, management. Until we have specific therapies, it's all about aggressive management of modifiable risk factors. Control hypertension, push for smoking cessationship. These are the strongest known levers we have to slow down disease progression.
So given everything we've discussed today, the surprisingly high prevalence, the clear evidence of systemic involvement, including large arteries, and the heart, the metabolic links we have to end with this final provocative thought.
Is the traditional name Cerebral Autosomal Dominant Arteriopathy with subcortical infarcts and leukoencephalopathy still fit for purpose? Does focusing solely on cerebral and subcortical adequately capture the reality of this disease?
Perhaps the evidence now compels us to think bigger. Maybe we need to start conceptualizing these conditions as NOTCH3 mutation spectrum diseases, a broader term that acknowledges the complex multi-system vascular failure this single gene defect can cause. Thinking this way might be essential not just for accurate diagnosis, but also for guiding the development of future, potentially systemic therapeutic strategies. That really is a major challenge and a fascinating direction for future research in neurology.